Okay, so in this video we're going to talk about, well, chapter 51. It's all about alterations in musculoskeletal function. So we'll talk about traumatic and conditions, infection, and disease. So for soft tissue injuries, we want to differentiate between contractile and non-contractile tissue. Now, contractile tissues are involved in contraction of muscle. This includes the muscle belly, the tendon, the bony insertion. So these are the portions of the tissue that will basically experience tension during an active muscle contraction. So if these are damaged, then you're going to find that there's pain during an active contraction. And with this, you'll see a decrease in muscle strength. Now, this is different than the inert or non-contractile tissues because they don't possess the ability to contract or relax. Therefore, they don't experience direct tension as the result of a muscle contraction. So this is going to include things like joint capsules, ligaments, bursa, fascia, dura mater, and nerve roots. Now, we can differentiate between the two because passive stretching will cause pain, and this generally causes altered range of motion around a joint that can result in pain, edema, adhesion, and fibrosis, but it's differentiable from contractile tissues because inert or non-contractile tissues aren't necessarily affected by muscle contractions. Now, other types of inert or soft tissue injuries include ligament injuries. And ligaments, if you all remember, were basically it's a dense, regular connective tissue that connects bone to bone. And ligament injuries can occur when loading exceeds the physiological range of motion. So basically like hyperextension or hyperflexion of a joint. And you might tear the ligaments associated with that joint. Now, microfailure typically precedes total failure. So you're going to find smaller ruptures before the entire ligament tears. It's classified by the extent of the tear, whether it's mild, moderate, severe, and the manifestations include pain with weight bearing, as well as acute swelling and maybe even a popping sensation if it's a ligament that supports a joint that moves a lot. Now, treatment depends on the degree of the tear, whether you may require surgical restoration, if it's a severe injury, or just protection of the ligament. That way it can actually heal back together if it's moderate or mild. Now, joint capsule injuries occur when there's injury that basically damages the surrounding tissue itself. And this is going to increase in blood vessels that can actually lead to a fibrous tissue that's thicker. This can actually limit the range of motion, and that's due to excess scar tissue that can build up. What we find that is also altered flow of synovial fluid might prevent proper diffusion of that fluid into and out of cartilage, which normally helps to nourish the cartilage, and if that's missing, then they can lead to cartilage degradation as well. Now, adhesive capsulitis is also called frozen shoulder. This is essentially where you have so much inflammation and swelling within a joint capsule that it leads to prolonged immobilization, which causes thickening of the capsule due to a buildup of scar tissue. Ultimately, this leads to a loss of movement. This can increase pain with movement, especially at night. And the treatment for this is intra-articular corticosteroid injections, as well as gentle stretching. That way you can improve the range of motion, help to improve the flexibility of that existing tissue, and anti-inflammatory medication can actually prevent additional scar tissue from forming. Now, the way that you want to prevent adhesive capsulitis or frozen shoulder is to basically avoid extended immobilization. And that way, if someone has joints injured, we want them to move it as much as possible without causing too much pain or further injury, because this is going to prevent that scar tissue that can lead to frozen shoulder or adhesive capsulitis. Now, it doesn't only have to occur in the shoulder, it can also occur in other joints, which is why it's more appropriate to generally call it adhesive capsulitis. Now, internal joint derangement refers to damage to tissues within the joint itself. So this is going to be tears to menisci or ligaments that result in joint instability. Now, this can cause restrictions of the joint that can lead to soft tissue dysfunction, which can lead to weakness and loss of motion or pain. Now, unfortunately, these internal joint tissues have little vascularity and sometimes very little nerve supply or innervation. So it often occurs without much pain. And so it's possible that someone might tear like a cruciate ligament in their knee joint and not even know it because they're poorly innervated. Now, these tissues also don't have great blood supply, so they also take longer to heal. So internal joint derangements are little bit more difficult to identify, and they also take longer to heal. Now, injuries to fascia and bursa are interesting because, well, fascia are the connective tissues of the body, and trauma can lead to edema and scarring. Now, remember, you find fascia between muscle and skin, and also around a muscle and within muscle. So restriction in fascia movement can also lead to joint restriction because these are the tissues that surround joints. Remember, bursa are pockets of connective tissue that are lined with the synovial membrane. And you find these between muscles or between muscles and tendons or muscles and bone or even between skin and muscle. Now, if they're inflamed, we call this bursitis, which can form a type of inflammation here that is very painful because these bursa are highly innervated. This is typically due to overuse and irritation of the bursa. Now, injuries to nerve roots, and dura mater are essentially where trauma of soft tissue can lead to constriction of these structures. Irritation or entrapment of the nerve can cause pain that radiates along the structures that innervate that nerve. So you might find that herniated discs can lead to distal pain, even though the disc itself is impinging on a proximal nerve. And manifestations include pain, altered sensation, whether it's like numbness or tingling, even motor weakness and diminished reflexes. So tendons, if you'll remember, connect muscle to bone. So injury to tendons is a contractile tissue. And because, basically these are the types of tissues that will experience tension during an active muscle contraction. And these, like ligaments, can range from mild to a complete tear. Now, it occurs when stresses placed on the tendons are greater than the fibers can tolerate. And it typically will begin as micro tears that lead to a complete tear. Now, tendinitis is inflammation of the tendon within the sheath. And this is basically from infection, direct injury, or repetitive motion. So something like carpal tunnel is a type of tendinitis you find in the tendons of your wrist. Now, strain versus a sprain is interesting. I mean, they sound similar, and it's easy to get them confused. But strains are damages to contractile tissues like muscles and tendons, right? So if it's a strain, we're talking about a muscle or tendon injury. And it's the range from minor tear to complete rupture, and it can be mild, moderate, severe. But that's really what differentiates the strain here is that this is contractile tissue. A sprain, on the other hand, is actually damage to a ligament, which is a non-contractile tissue. So you'll see that these have differences in pain because a strain will be painful upon an active contraction, and a sprain will be painful upon just moving the joint, passively. Now, blunt trauma can cause bleeding into a muscle belly, which can limit the ability of that muscle to contract, and that actually may even coagulate and calcify. And calcified blood within a muscle can lead to chronic irritation, which can limit muscle force and lead to muscle weakness. Now, one interesting feature of joint and tissue injury is something called compartment syndrome. This is a dangerous complication of soft tissue injury that results in swelling of the injured tissue within a restrictive fascia. This is the key here, is that if you get excess swelling within a restrictive area, that actually decreases the size of the compartment, which increases the pressure within that compartment, and that edema can increase so much pressure that it reduces capillary flow. Now, remember, blood only flows from high to low pressure. So if you find that pressure increases dramatically within a restrictive space, blood might not actually flow there, especially if it's higher pressure. So muscles and nerves may become ischemic, and if the pressure is not reduced and blood flow is not improved, the tissue can become necrotic, right, due to avascular necrosis. And then you have irreversible cell injury, which is basically cell death. And that can really lead to damage within specific areas of your body. Now, other considerations of soft tissue healing is that, yes, you might see disruption of circulatory and lymphatic systems. You might get hemorrhage or fluid loss, and these can lead to cell death. Remember, inflammation leads to the release of histamines that cause vasodilation. Now, this can increase the permeability of blood vessels, which can lead to edema. And if there's too much edema, that can lead to compartment syndrome. Now, it may take up to 40 weeks for these soft tissues to heal, right? So close to a year before these soft tissues can fully heal. Now, in terms of bone and joint trauma, we know that the function of bones is to protect internal organs, to contribute to mineral homeostasis, produce blood cells, and provide muscle attachment sites. And they're one of the body's hardest structures because they are made of collagen, which is a strong protein, as well as mineralized matrix called osteoid. And it's vascular with a capacity for repair, so bones can repair pretty easily. Now, types of bones include compact versus spongy, which we saw in chapter 50. Compact bone is also called cortical bone, surrounds the outside of bone. Spongy bone is cancellous bone. It's more spongy in appearance, it's less dense. It actually helps to lighten bone because it has a lattice-like appearance that is less dense than compact bone. Now, there's different types of fracture that can occur, and these are just basically dependent on the appearance of the break. And these basically depend on the types of stresses that are involved. And it's classified based on the orientation of the break, whether it's transverse or longitudinal, or oblique or spiral. So transverse is a horizontal kind of plane, so it goes across. Longitudinal means it's going down the length of that bone. Oblique means it's sort of a sideways angle at a 45-degree angle to the longitudinal length. And then spiral means it sort of wraps around the bone. Now, a comminuted fracture is one where there's more than one fracture line, and therefore the bone kind of separates into multiple fragments. Impacted means that the bone telescopes or invaginates within itself, so one segment of the bone drives within another. And a green stick fracture is where you have an incomplete break, where one side of the bone is fractured but the other side is not, almost as if you're breaking a stick that's not quite dry yet. So this is showing just a picture of the different types of fractures we mentioned here. Remember, transverse goes across, spiral wraps around the bone, longitudinal goes in the length of that bone, oblique is a 45-degree angle here. Comminuted is where you have multiple fracture lines, so you have lots of different fragments here. Impacted is when the segments of bone can sort of drive into each other. Green stick is where you have a fracture, but it's almost as if you're breaking a stick that's not dry. So you have one side that's intact and another side that's fractured. And a stress fracture is just kind of like a hairline line fracture, really anywhere in the bone that's due to excess stress. Now, another interesting one here too is called an avulsion fracture. An avulsion is basically where the bone gets pulled apart. So there's a fracture line at the place where basically the bone couldn't resist that stress, and the bones get pulled apart. It's common in the patella due to contraction of your quadriceps muscles, where the quadriceps pull on the patella this way, superiorly. However, the patella is also anchored to the tibia inferiorly, and because this is a place where there's a lot of stress, the bone can get pulled apart. That's an avulsion fracture. Now, the extent of fracture can be either non-displaced, which means that the fragments are in their normal position. If it's displaced, we're saying that the bones are out of their normal position. A depressed fracture is basically where the fragments are displaced below the level of the normal bony surface, so it looks like a divot. Complete break is where the bone is broken all the way through, so you have two separate halves now. And then an incomplete break is where the bone hasn't broken all the way through, but only buckles or cracks. We can also classify the fracture based on whether it's penetrated the skin or not penetrated the skin. If it has penetrated the skin, we call that open or compound. If it hasn't penetrated the skin, we call that closed or simple. Now, this is showing a complete fracture versus an incomplete fracture because these parts of the bones are still connected. And this is an open fracture versus a closed fracture, also called compound versus simple. So if it's compound fracture, we call that open. That's where the bone is actually penetrated through the skin. And if it's this closed fracture, we call that simple. That's where the ends of the bone are fractured, but the skin barrier is not compromised. Obviously, this open or compound fracture is going to put you at a higher risk for infection. So in terms of healing, we talked about back in chapter 50, we said that the first stage of bone fracture repair is hematoma formation. That gets converted to a fibrocartilaginous callus, which is converted to a bony callus, and then that's remodeled over the course of years. Now, in terms of treatment of bony fractures, the goal here is to reduce the amount of mobility of that bone. So we want to restore normal limb position, and it's considered emergent if there aren't any concerns for neurovascular compromise or the potential for ischemia within that limb. Now we want to immobilize the bone. That way we maintain proper alignment, and this actually helps to improve healing time and reduce additional fracture. Icing helps to prevent too much inflammation. Elevating also prevents too much inflammation. And immobilization also helps to improve healing time by preventing further injury. Now, ways we can treat the fracture with casts, splints, or braces. These are all things that can help to immobilize our bone or the region of fracture. Surgery can actually be internal or external fixation. Internal fixation would be plates or screws that attach the bone together. External fixation is where we have devices that are applied temporarily externally and can be removed once the bones have started to heal together. Now, bone grafting could be an important way to help to improve healing time, where essentially what we have is cadaver bone that's been sterilized, and so it's just bony material without any living cells or antigens, and effectively this bone graft serves as a substrate for bone to heal into. We also have electrical bone stimulation. This is a fascinating procedure where by applying a mild electrical current to bone, it stimulates osteoblasts to try to basically become more active, and it improves healing time. We may also have antibiotic prophylaxis, right? So antibiotics are a way to help to limit microbial growth, and so if you suspect then that someone's at risk for microbes growing in response to their fracture, antibiotics can be useful to prevent, necrosis associated with infection. Now, some complications of fractures include things like delayed healing, and the delayed healing could lead to delayed union, where it might take anywhere from 3 to 6 months after the fracture for the bones to come together. Malunion is basically where the bones heal together, but there's an improper alignment of the fracture fragments, so the bone is not, sort of how it used to look. And the non-union here is where the ends of the bones actually don't heal together at all. And this might be up to 6 months after fracture. Now, osteonecrosis can result if blood vessels have been compromised and entire segments of bone don't get enough blood flow. This can lead to, basically osteomyelitis, and we also get neurovascular injury if we don't get adequate blood flow. Now, complications of fractures can also include things like compartment syndrome, we talked about earlier as being an excessive amount of pressure that can lead to ischemia. Deep vein thrombosis can also occur as well if we get poor circulation as a consequence of that fracture and venous blood builds up in the distal extremity. These venous blood can clot in response to stasis or even injury to the venous wall, and this can put you at risk for pulmonary embolism because these clots can dislodge and then travel to the lungs. We also can get fat emboli syndrome, where basically yellow bone marrow can leak out of the bone, enter your bloodstream, and then effectively form an embolus somewhere else in the body, but it's basically made of yellow bone marrow. Now, dislocation versus subluxation, the difference is that dislocation is a complete separation of the joint, whereas subluxation is only a partial separation of that joint. It's where we have a considerable amount of tissue damage and pain, and we might have a normal contour of the joint, but we might have a change in the extremity length. And this you're going to see during subluxation, where there's partial separation, where the joint is normal contoured, but because they're partially separated, one limb might be longer than the other because of that increase in distance in the joint cavity. Now, it's treated as a local soft tissue type of trauma. So you want to have a little bit of immobilization, you want to help hold that joint position, and help to improve blood flow and reduce too much swelling to improve healing time. Now, osteomyelitis is a severe pyogenic infection of bone. So we say that the organisms reach bone either through the bloodstream or through adjacent soft tissues through direct, basically introduction of organisms into the bone, and this can actually lead to necrosis of the bone. Now, if it's not treated and managed, it can lead to necrotic bone that can separate from the healthy bone in dead segments called sequestra. And these sequestra are basically infected necrotic segments of dead bone. And this is treated with weeks of antibiotics, and abscesses may form, which might require some debridement, which is essentially, physical removal of that particular dead segment of bone. If it's severe enough, it may even require amputation and can lead to chronic infection. Now, tuberculosis also infects bone because this microbe, although it prefers the lung tissue, can also live in bone, especially the vertebrae because they're close to your lungs. So we see that it actually gets to your bone through either lymph drainage or bloodstream. And the most common site is the vertebral column. You get local pain and low-grade fever. There's weakness of lower extremities due to nerve involvement. And the treatment includes long-term antibiotic therapy for 6 to 9 months to try to kill off this Mycobacterium tuberculosis. Now, it can be complicated by drug resistance because there's a lot of antibiotic-resistant strains of tuberculosis out there now. And surgical intervention may be required if you can find localized areas of tuberculosis that can be surgically removed as long as it's pinpoint and not diffuse. Now, scoliosis is one of these bone structure disorders, and it's a lateral curvature of the spine, which may be S or C-shaped. Now, non-structural scoliosis resolves when the patient bends to the affected side. So if they have a C-shaped spine and they bend to the affected side, it might actually resolve itself. So it kind of pops back into normal shape or position. So it's a little bit more bendable and flexible. This differs from structural scoliosis because this is actually where the bones are so, fused in position that it fails to correct itself if you have forced bending. Now you'll see asymmetry of the shoulders, hips, and chest wall. And due to this asymmetry and pressure on the chest wall, this can lead to obstructive pulmonary disorder, so respiratory problems. And treatment for this involves bracing and exercise, and maybe even surgical repair through spinal alignment, fusion, or fixation. So this is showing an example of scoliosis here. You can see that S curve here. Remember, if it's a non-structural form of scoliosis, if the patient bends their affected side, then it'll resolve itself, and the spine will kind of, stay in position, anterior, so superior, inferiorly. However, if it's structural scoliosis, then it won't resolve itself, and it'll stay in this position. Now, osteoporosis we consider a metabolic bone disease. It's one of the most common metabolic diseases. So it occurs when the rate of bone resorption is greater than formation. What we find is that the trabeculae or spongy bone decrease in amount, in width. This overall decreases your bone mass, which makes bone more fragile. Now, cancellous bone is lost faster than cortical bone, so you find more spongy bone lost before you have compact bone. However, spongy bone plays a significant role in the structure of your bone. So, although it's spongy, by losing that structure, you still make bones weaker. Now, the etiology of osteoporosis relates to estrogen deficiencies. So you see this more commonly in postmenopausal women because after menopause, their estrogen levels decline since their ovaries aren't releasing them anymore. And this can lead to osteoporosis. Possibly even relates to poor calcium intake and disuse due to atrophy. Now you can see the difference between healthy healthy cancellous or trabecular bone and osteoporotic bone. So you can see that this one looks, sort of thinner and weaker. And overall, although this is at a microscopic scale, it makes the bone, just more brittle. And it makes sense because this even looks more brittle, even at a microscopic level. Now, other metabolic bone diseases include things like rickets and osteomalacia. Now, these are both caused by vitamin D deficiency. We know that vitamin D is necessary for proper calcium absorption. We call it rickets in children, but osteomalacia in adults. Now, the etiology is just dependent on what that source of vitamin D deficiency is due to, right? So, but we know that vitamin D is necessary for calcium and phosphorus absorption. So if you have poor vitamin D metabolism, then you're not going to be able to absorb enough calcium and phosphorus in your diet to support your bones, so your bones become more brittle. You can also see this as as a consequence of renal disease because the kidneys help to synthesize and release vitamin D, and if the kidneys are failing, then you can't help to absorb as much calcium. Now, it's treated with vitamin D supplementation, calcium and phosphorus supplementation, and if you can restore these nutrients, then you can help to reverse this type of bone disease. Now, Paget disease you can think about as being the opposite, where it's slowly progressive wasting of bone, but that's followed by excessive bone formation. It's probably genetic, but may also be due to viral infection. And this leads to painful bone deformities that make bone weaker in some ways, and so bone fractures can develop due to overgrowth of bone. And during the active stages, the treatment's really focused on preventing bone deformities. So this is actually achieved with calcitonin and biphosphonates, which actually help to reduce blood calcium levels. Now this slide here is showing an example of Paget's disease, and you can see that due to overgrowth of bone, the skull is less smooth. You can see it's more bumpy in appearance and thicker. You can see that the nasal cavity is narrowed instead of being wide, so this individual would have difficulty breathing then. Their orbits are also more compressed due to an increase in bone mass in the frontal bone here, and the maxilla and the sphenoid as well, so that they would have been blind due to compression of the eyes. And you can see their maxilla as well as their mandible are also thicker, so they may have actually had some, some oral problems as well. Now, bone tumors can be benign or malignant. Now, these malignant bone tumors are referred to as sarcoma, so if it has like osteosarcoma, we know it's malignant. Now, these lesions can spread to bone from other carcinomas, so you might find that like breast cancers or prostate, lung, or kidney cancers can spread to bone because bone is highly vascular. But some common sites of metastasis include vertebral bodies, the pelvis, as well as the proximal ends of your femur and humerus and ribs, because these are highly vascular areas of bone. Now, in terms of the benign bone tumors, we got osteochondromas, chondromas, osteoid osteimas, and giant cell tumors. The osteochondroma is a cartilage-forming benign tumor that's heritable. Chondromas are cartilage-forming bone tumors that are located in the medullary cavity. Osteoid osteomas are painful and benign bone-forming tumors. And a giant cell tumor is also called an osteoclastoma because it's basically a tumor of the osteoclasts. It's aggressive but benign. It's also richly vascularized with abundant giant cells. So you're going to see these sort of cysts that form where there's localized degradations of bony tissue. Now, the malignant bone tumors include osteosarcomas, which are extremely malignant bone-forming tumors, and they're the most common. We got chondrosarcomas, which are malignant cartilage-forming tumors that will develop more slowly. There's an Ewing sarcoma, which is the third most common, and it rapidly grows. It's malignant of the round cells, so it's derived from red blood cells. And multiple myeloma is a slowly growing bone marrow malignancy that's, has neoplastic proliferation, but it comes from plasma cells, so it has an immune cell origin. Now, other diseases of your skeletal muscle include things like muscular dystrophy. Now, before we talk about that, we'll go over the function of skeletal muscle. So, skeletal muscle is the most abundant tissue in your body. It actually accounts for about 40% of your body's weight. It performs dynamic and static work, but it atrophies in response to disuse or deinnervation, and it hypertrophies in response to increased use. Now, muscular dystrophy is a group of genetically determined myopathies that lead to progressive muscle weakness. Now, the muscle tissue is eventually replaced by fat and fibrous connective tissue, and it's classified by the pattern of inheritance, the age of onset, and which muscles that are affected. So the first type we'll talk about here is the Duchenne muscular dystrophy. It's the most common severe form. It's heralded as an X-linked trait that only affects men, and muscle cells are deficient in this protein called dystrophin. Now, dystrophin weakens the cell membrane, allowing extracellular fluid to leak in the cell, and eventually leads to cell injury and death. Calf muscles become enlarged. You're going to find larger gastrocnemius and soleus, as well as distal muscle involvement. Typically, these individuals will be wheelchair-bound by 12 to 14, and due to muscle weakness, they get respiratory failure, and that leads to death by age 20. Now, treatment includes corticosteroids to induce or reduce the inflammation, and you get some preservation of function here. Now, Becker muscular dystrophy is a little bit more mild form, and it's also heritable. However, it leads to more slower muscular degeneration. It's similar because you see abnormal dystrophin. You also get calf muscle hypertrophy and progressive loss of strength, usually in a wheelchair by 30 rather than 12 with Duchenne, and they might lead normal lives as long as their respiratory muscles aren't affected. Now, facioscapulohumeral muscular dystrophy is more rare. It's autosomal dominant, and what we find is that it affects the muscles of the face and shoulder girdle. So you find that facial muscles are involved early, and then later on the shoulder and upper arm musculature. Now, it progresses more slowly, and it could eventually involve more distal muscles. Most of these individuals live to a normal age, but again, they're going to have facial muscle paralysis and shoulder and upper arm muscle paralysis as well. Myasthenia gravis is actually an autoimmune disorder of skeletal muscle. So it's where your immune system attacks the acetylcholine receptors on skeletal muscle. There's actually antibodies that destroy and block these receptors, and it actually prevents the neuromuscular junction from communicating. So you get profound muscle weakness and fatigability. Now, it's treated with drugs that increase the amount of acetylcholine in the synapse, but it's also treated with other methods that help to reduce the inflammatory immune response, like corticosteroids, as well as immunosuppressive agents, and removing those autoantibodies through plasmapheresis or blocking those antibodies with immune globulin. Fibromyalgia is actually a chronic muscle pain syndrome whose etiology is unknown, and it's possible due to a central sensitization due to prior infection or trauma. It's characterized as widespread pain in all quadrants, and symptoms can include things like fatigue, insomnia, depression, as well as concentration problems from that pain. There are tender and trigger points as well, but it's treated through things like exercise, counseling, and drug therapy, improving sleep, mood, and pain, as well as a drug called pregabalin. And all these can actually help reduce the pain that's associated with fibromyalgia syndrome.